Hi, today we're going to talk about Nivolumab plus ipilimumab in lung cancer with a high tumor mutational burden. Definition: lung cancer, also known as lung carcinoma, is a malignant lung tumor characterized by uncontrolled cell growth in tissues of the lung.
There are three main treatments for lung cancer: surgery, radiotherapy, and chemotherapy. The treatment you need depends on what type of lung cancer you have, where the cancer is, and your general health. You may have an operation to remove the tumour and some surrounding tissue. This may mean the surgeon removes a section of your lung, a lobe, or the whole lung. It is suitable for some types of lung cancer that are at an early stage. Radiotherapy is the use of high-energy rays. You may have it on its own, or with another treatment such as chemotherapy or surgery. The amount of treatment you need depends on your cancer. Each treatment lasts for a few minutes. Chemotherapy is the use of anti-cancer drugs to destroy cancer cells. You may be given chemotherapy alone or with other treatments. You have most drugs by injection or through a drip into your bloodstream, but some are tablets that you swallow. Most people have chemo as an outpatient, but you may need a short stay in hospital. You can find out more about these and other treatments for lung cancer on the Cancer Research UK website.
Applications in medicine. Nivolumab plus ipilimumab show promising efficacy for the treatment of non-small cell lung cancer in a phase 1 trial, and tumor mutational burden has emerged as a potential biomarker of benefit. In this part of an open-label, multi-part phase 3 trial, we examine progression-free survival with nivolumab plus ipilimumab versus chemotherapy upon patients with high tumor.
It's a strange situation where the drug combination is not yet FDA approved for that indication and yet has been included in the NCCN guidelines. So as a clinician, you're thinking to yourself, well, it's not yet FDA approved, but if I know that insurers will pay for it, is this a good option for my patients? Especially those who have responded to chemotherapy, who have not responded to chemotherapy or recur very quickly. And I think the caution there is that this is a toxic regimen. I think that it needs to be, the toxicities can be managed very well, but you really need to know what to look for, and you need to be careful in your selection of patients who can receive this regimen. But in general, it's a tremendous milestone for the field of small cell and for those patients that we have these new options, these new tools to use and develop. And then I spent a lot of time looking at different combinations of these new immunotherapy agents in combination with chemotherapy and so forth in the small cell space.
Pros and cons. The pros are that it helps to control the growth of cancer cells, and the cons is that the treatments are very harmful and can have many side effects like liver problems.
So it was critical to conduct this analysis of the Checkmate 069 study to really assess the longer-term outcomes in this group of patients. We saw from our first analysis of this data that there was very impressive response rate and progression-free survival differences with about a year of follow-up. However, what's really important for our patients is how does this look now at 2 years of follow-up? and the analysis that we presented today included that longer 2-year follow-up data. The primary information that we presented from this study, number one, we conducted follow-up on the progression-free survival in BRAF wild-type patients and in all randomized patients. And also importantly, for the first time ever, overall survival data from this study were presented with 2 years of follow-up. So grade 3 or 4 adverse events did happen, and they happened to a greater amount in patients that got the combination treatment compared to ipilimumab monotherapy. The ones that were the most common affected the GI system, so diarrhea and colitis, and these are side effects that had been seen in other patients treated with these types of antibodies in other trials as well. But also there were liver toxicities, so patients had inflammation of the liver. AST and ALT were elevated in patients that received the combination, more so than that got ipilimumab monotherapy. But what's also important to keep in mind about these grade 3 or 4 side effects is that the majority of these patients had resolution of these side effects when immunosuppression was given to treat the side effect. So I think the biggest advantage that we see so far with the combination compared to ipilimumab alone is that you have a much higher response rate. So the tumors shrink to a much greater extent in a much larger proportion of patients than ipilimumab monotherapy. And it appears that the patients that get the combination go for a much longer time before their tumors get worse, also with the combination. I think the incorporation of the PD-1 drug nivolumab really adds substantial clinical activity. And we've seen superiority of PD-1 antibodies over ipilimumab monotherapy in a number of studies. And so I think incorporating a PD-1 antibody is very important in the treatment of patients with advanced melanoma, and this combination is just another good example of that. So what is most important about this combination is how the overall survival looks in the phase 3 study. So all the data that we talked about today were from the phase 2 study of the combination versus ipilimumab alone. But what's really important is to look at the phase 3 study where overall survival was a primary endpoint, and to see how well this combination performs against ipilimumab alone in that study, and also importantly how nivolumab monotherapy in that phase 3 study performs against ipilimumab monotherapy. So I think we're doing a lot better in melanoma in general, and we were very enthusiastic for all of our patients. We're seeing long-term survival rates now with either one or even both immunotherapies that has really not been seen before. And so metastatic melanoma, it's certainly a very serious diagnosis, but I think the key take-home for clinicians is that we have a lot of new treatments now, and these can greatly benefit patients. So we need to make sure we're treating patients with these new treatments so that we can optimize patient outcomes as best as possible.
About issues applied in Ecuador. Between 2006 and 2010, the incidence rate of this cancer was 7.9 per 100,000 inhabitants of Quito. There were 2,561 cases in this period, so it was an increase of the cancer.
In the first part of the presentation, we examined the updated response data for patients in the non-randomized cohort. In this part of the study, about 150 patients were assigned to receive either nivolumab or nivolumab plus ipilimumab. Using the blinded independent review of scans, the response rate to nivolumab plus ipilimumab was 23% compared to 11% with patients who received nivolumab. In contrast to other diseases, in small cell lung cancer, PD-L1 expression seems to be very uncommon and not predictive of response, so that there was actually numerical increases in response rate amongst the patients who were PD-L1 negative compared to those that were PD-L1 positive. And so it doesn't seem that PD-L1 is an important biomarker for response in this disease. But building on that initial efficacy, we then extended the survival analysis to examine longer-term outcomes and found that 2-year estimated survival of patients treated with nivolumab plus ipilimumab was 26%, compared to 14% in those who received nivolumab. And those sort of long-term survival numbers are generally not possible in this disease, which is rapidly progressive and rarely sees patients survive to 2 years. I think is indicative of the long-term benefit that's possible in the subgroup of patients who really benefit from immunotherapy. We next moved to the randomized portion of the study, in which about 250 patients were randomized to receive either nivolumab or nivolumab plus ipilimumab. This is the first time this data has been presented, and as a result, the outcomes are still premature and follow-up is not long. But the response rate was the main focus of this part of the presentation. And in the randomized cohort, the response rate to nivolumab plus ipilimumab was 21%, compared to 12% with nivolumab monotherapy. And so those response rates were very similar to what had been seen in the previous part of the study, and confirms that this efficacy that we're seeing seems to be real, even in a randomized setting. The next major part of the presentation related to the pooled analysis of all 401 patients who were treated in both the randomized and non-randomized part of the study. We found that responses were seen in both second line and third line and beyond, and that responses were seen in both the platinum-sensitive and platinum-refractory patients. So these sorts of treatments, this sort of immunotherapy, can be beneficial for patients in a variety of settings, and platinum sensitivity didn't seem to determine response. We next examined safety across the whole across the 401 patients that were treated, and found that safety looked quite good amongst the patients treated with nivolumab, where only 12% of patients had any grade 3 or 4 toxicity, and only 2% of patients had to stop treatment due to some toxicity. As has been seen with other combination immunotherapy studies, the degree of toxicity was somewhat increased in the nivolumab plus ipilimumab arm, where about 35% of patients had some grade 3 or 4 toxicity. But that rarely led to discontinuation of treatment, where that happened only in 10% of people, and almost all of the immune-related events were able to be controlled and ultimately resolved with immunosuppression or holding drug.
So about the conclusion is that by this treatment, patients can survive significantly longer with the first-time nivolumab plus ipilimumab than with chemotherapy. The results validate the benefit of nivolumab plus ipilimumab burden as a biomarker for patient selection. Thanks.